I'm Myles Leslie. I'm the Associate Director of Research at the School of Public Policy at the University of Calgary. Part of what's going to happen and what has happened as the first wave has come, and we're now looking at reopening, but in that 9 or 10 weeks that we had there, there's an awful lot of information that's flowing around. As information flows, the basic premise of the grant that we put together was each time it gets transmitted or received, there's going to be a layer of culture or a layer of context that's going to interpose itself, because people have to decode it, figure out what it means for them in their environment, and then either pass it along or not. Something starts at, say, the WHO or the Centers for Disease Control. It's a piece of guidance. It's who you're supposed to test and when you're supposed to test them. And that comes down through the Public Health Agency of Canada into the provincial systems. And then at the provincial health level, it here in Alberta transfers from the Ministry of Health into the Alberta Health Services. At each one of those steps, it's a little bit like being in grade 5 again. It's a telephone game. Somebody picks up a phone and says, this is what you're supposed to do. And somebody else who picks up the phone on the other end goes, right. And so how do I do that here? That gives a whole bunch of space for somebody who works in the social sciences, in culture and context, to work and to try to help as well as just study what's going on. Because every time the message is passed, it's going to be filtered through the culture and context that are happening there. We've got a couple of examples of things that we've been following. What do I mean by that? Things like a protocol that was developed in one place. And as we follow it, who made it, how it was made, the parts out of which it was assembled, who actively tried to block it, who gave it space and some fertilizer and it could grow. As we do that, we get a sense for what it is that might be part of the special sauce or the fairy dust or whatever it is that allows something to spread and scale. The questions that need to be asked over the next year in the reflective time that nobody has had for the last 2.5 months is, yeah, but does any of that apply outside of the crazy rules of a pandemic? Can you actually bottle any of that and call it special sauce or fairy dust or whatever else? Or do you have to say, no, that was a one-off? We found that rather predictably, chains of communication, which had been worked on quite assiduously in the wake of SARS and H1N1, still left something to be desired. I think the media version of that might be, we've got to go out and fill all of those cracks and make sure that there's no possible breakages in a line of communication. I think the more realistic sociological understanding of that would be that when human beings communicate with one another, there will always be interpretive issues and there will always be implementation issues. Have we done the best job we can to try to make the system as robust as possible? And I would argue from our early findings here in Alberta that Alberta has done an incredibly good job creating relationships and creating structures that people understand and are interacting with rather than are like rules that sit on a page somewhere. One of the features of the pandemic is that we have to retask spaces and people. So spaces that were once conference centers in Spain were turned into morgues. We have to retask people that were doing something very different than what they started out in some of their days, ended up doing things that were COVID related. Specific example of that from our work is a unit in a hospital that normally would handle patients who'd had their hip or their knee replaced and had a very consistent trajectory of you will wake up at this time, then you will try to bear weight on the new joint by this time, and we will send you home by this time, are suddenly told that within 3 hours, their entire floor will be evacuated of the existing patients, and they will be set up within 6 hours as a COVID treatment area. That's a switch from doing surgical recovery to medical respiratory care. Big deal, big switch, very short period of time. And in identifying, because we were out there monitoring the hospitals, observing as the hospitals prepared themselves, that this was a really big deal, particularly for this group of people, we put our team together. This is the infection prevention control, human factors, and organizational sociology, and deployed to that unit to help them get through that transition. As the stories I've told indicate, we've got public health professionals and acute care providers and primary care providers all directly benefiting from the team's work and the feedback that we're able to give them and the insight, that sociological insight, along with feedback about dropped connections and that sort of stuff. So if those are the initial interactants that you would actually run up against and who would benefit from this, then there's the people who they're caring for because of the work that this team has done. Patients who showed up on the COVID unit that I've described, patients who are moving through the clinics and in the primary care facilities that I've described. Patients that are calling into the hotlines where we've also been interviewing people. They're benefiting from the sociological insight and the social science work that's being done in the background.